Eva, as the surgeon, is there any difference intraoperatively between the two, LAL versus LAL plus? Do you find that there's any nuance
Um,
or
nope.
LAL compared to other lenses?
Oh, yes. Yes,
Okay.
absolutely. So LAL to LAL plus, no difference. I always kind of look at the LAL plus to see if I can see a,
And
central elevated area. And every now and then I'll get a little flash of some, like a just notable circular area, but generally no difference. And I've actually asked my technicians that who fold the lenses if there's any difference in the way it feels, and they always say there's no difference. But yes, gosh, LAL, I implant a lot of them, but they just continue to make me just a little bit nervous when they're going into the eye because um, when you are inserting the IOL into the eye, unlike a lot of the softer, gummy acrylic lenses, this lens comes out, halfway out of the inserter and it just flings open like a plate. And it never has yet, but it feels like it's going to open up so quickly that it will break the bag. So I am so careful about making sure that the capsular bag is as full can be with viscoelastic so that the haptic, doesn't sort of tear through the bag. It feels like if it's underinflated that, you're really asking for some trouble there and it's going to break through the posterior capsule. It never has though. The nice thing about the three-piece silicone lens is that if there is rupture of the posterior capsule, unlike the one-piece soft acrylic lenses, you can choose to use this IOL still in the eye. You don't have to remove it. You can place it in the sulcus. You can decide whether or not to optic capture. It's probably a good idea to do that if you can for stability's sake, so it stays centered. But it's really nice because when you have a posterior rupture with a typical one piece lens, that lens is not allowed to stay in the sulcus. So you have to pull that lens out, cut it up and take it out, and then pick another acrylic or silicone three-piece lens to put into the sulcus. So
yeah, and by doing that, you would have a higher chance of inducing surgically induced astigmatism. Becomes a lot more problematic. Um, I guess if you've never seen it, I mean, Seamus, my next question was, would that, if there's a sulcus placed LAL, would that change your strategies during the light treatments? I guess hypothetically.
Thank goodness that hasn't happened yet, as said. I think I'd be a lot less aggressive with treatments, like definitely going to, like cross my T's and dot my I's with that. I think yes, I'd probably, even the first time that I would experience that, I'd probably bring like a member of RX site into the fold for some counseling on that. Just maybe not something I want to troubleshoot by myself. And I'm not ashamed to say that. I think that would be, stakes are a little bit higher and you want to still give them the same outcome. So I don't know. I'm sure that one day something will come across my plate like that, but I will
hopefully not. Hopefully not.
Yeah.
So I'll make a comment about that. I have treated a sulcus IOL. I've treated several sutured light adjustable lenses in patients who have had dropped lenses. And by having a retina doctor, I have a really great friend and colleague in the community who has done vitrectomy, and then he actually cares about refractive outcomes, and so we have this little partnership where he will do Yamani fixation of LAL, and then I'll do the treatments for the patients. So that's been a nice partnership. He'll send them to me for the treatments, and it really is like, I think the only difference is these patients are so grateful to have the opportunity after a dropped lens, usually because they had trauma or like a white cataract or dense cataract, and they end up having this like amazing 20/20 vision, after all the light treatments. Like, so that has been really exciting for these patients.